So good morning, guys. I got a catchy title, Grand Rounds. So I was hoping Dr. Denny was going to be here. I need a ringer, but he'll show up. So I'm going to go ahead and start with a case, as I often like to do. This 58-year-old man, he presents after a fall onto his left shoulder, and he's got pain, limited range of motion, no neurovascular deficits. Here's the X-rays. Dr. Massey, you want to give us an interpretation?
Looks like this is the same patient that we looked at, right?
Yeah. 2 views. There's more views. I didn't include all of them.
Almost looks like there's some AC separation. Very little maybe. And then his shoulder might be dislocated.
Shoulder might be dislocated. All right, I'll go with that. So anterior shoulder dislocation. There's the humeral head. Here's the glenoid. It's not where it belongs. So we did what we do sometimes with shoulder dislocations. This guy was relatively healthy, so we gave him some propofol, and we tried to put it back. So I'm just going to replay a conversation that I had at the bedside, and you guys can tell me if you ever had a similar conversation. Is it in? I don't know. I thought I felt something. Did you feel something? Let me try again. All right. I don't know. Do you think it's in? Should we call X-ray? I think it's in. Let's just call X-ray and we'll see. Anybody ever had that experience with a shoulder dislocation? All right. So that's the intro to our topic today is musculoskeletal ultrasound in the ED. It's a pretty big topic, so I'm going to focus on some of the things that I think are the most useful, but realize that this is now a whole subspecialty of ultrasound, and people are coming up with new musculoskeletal ultrasound techniques every day. I don't have any disclosures, and for CME purposes, I'm going to go over the objectives. We're essentially going to talk about joints, bones, and tendons. We'll go over the indications to do ultrasound, how to get images, what things should look like and what things shouldn't look like, and how ultrasound can help you with some of the procedures that we're going to talk about. In general, the reasons to do a musculoskeletal ultrasound is because somebody has pain or swelling, a change in their range of motion, they've had trauma. The easy thing to remember is you think there's something wrong with their bone, their joint, or their tendon. That's a pretty decent reason to ultrasound it because there's no downside. Or to guide you in a procedure. So I'm going to start with the shoulder. I'm going to kind of work my way down. Then we'll get to the lower extremity before we move on to the next section. Who's done any ultrasounds of the shoulder? Anybody? Just me and my counterparts that day on this patient? All right. Just a quick review of the pertinent anatomy of the shoulder. So this is the back view and the front view. And what I'm going to point out really from the back, if you follow the scapular spine, you get the acromion, and just about usually a finger breadth or thumb breadth under there is where the glenohumeral joint sits. And you might remember that from when you do these injections, because we less often do procedural sedation for shoulder reductions than we used to. We inject them instead. And that's your anatomy. And anteriorly, you've got the coracoid process, and it sits just anterior and a little bit superior to the glenohumeral joint. And that's going to come into play with the ultrasounds that we'll look at. So the technique, pretty much everything that we're going to talk about, we're going to be using high-frequency transducers because we're going to be looking at pretty superficial structures, and we want as much detail as we can get. In some cases, some of our obese population, you might use lower frequency transducers to get more penetration, but mostly high frequency. For the shoulder, it's mostly a transverse technique. So you're looking right across the joint in a transverse plane, and we're going to talk about the anterior approach and posterior approach. And for what we mostly see, the most common shoulder dislocation is an anterior shoulder dislocation, so most of the time a posterior approach is what we're going to use for shoulder dislocations. So the technique is, you got your high frequency transducer, you come up right where the humeral head should be and find the glenohumeral joint. And here's what it's going to look like on ultrasound. Infraspinatus tendon comes across back here. Here's the nice round humeral head. It's bone, it's dense, so it's bright white and casts a black shadow. And this is the glenoid rim right here. And this is normal. This is what it should look like. Right here is the synovial membrane, and that's normal. If someone's got an effusion, you'll see that distended with black fluid. Anteriorly, so about the same approach, you're just about the level of the coracoid process. So here's the coracoid process right here, and there's the humeral head. And that's normal anatomy. That's what you should expect to see. So these are some abnormals. This is the left shoulder, posterior approach. Here's the glenoid. I don't remember why they labeled these A and B. Here's the humeral head, and it's anterior. You think about your slicing patient this way. So this is the humeral head anterior to the glenoid. And here it is post-reduction. There's the glenoid, and there's the humeral head that sits right up in it where you expect to find it. So I see that. So this is a nice technique you can apply quickly before waiting 10 minutes to get an order, radiology to come over, do an X-ray. Now your patient's awake, and you've got to give them some more sedation if you need to make another attempt. So in case you didn't see it, that's out and that's in. So these are just more examples. So here's the glenoid, that dense white with a shadow. Here's the humeral head that's anterior in the wrong place. And there's some effusion here because of the injury to the joint. So if you want to do an ultrasound guided joint injection, right here is where you want to stick your needle. Some more examples posteriorly. There's the glenoid rim. There's the humeral head, not where it belongs. Here it is after it's back in. Humeral head takes up a big part of the screen. There's that dense white glenoid rim. Out and in, if you didn't see it. So here's the anterior approach. Now this is still an anterior shoulder dislocation. Here's the coracoid process, but there's no humeral head. Some people call it the missing humeral head sign. Because remember, in an anterior shoulder dislocation, the humeral head is anterior, but it's also inferior to the glenoid rim. So that's why it goes away in this anterior approach. And then after reduction, you see the coracoid here, and now you can see that humeral head up where it belongs. So again, if you wanted to inject their joint to prepare for the reduction, here's your target. Here's the shoulder dislocation, there's the glenoid rim, there's the humeral head. You want to stick your needle right there, and here's an illustration of how you would do that. They kind of neglected the sterile prep and all that for illustration purposes, but if you do this, please do a sterile prep and drape. Again, there's your needle's target right there. So anteriorly, again, what your big landmark anteriorly, if you've got a shoulder dislocation, is the coracoid. Now remember, the glenohumeral joint sits a little bit inferior to that, so you're going to use that as your marker. And if you do a mapping technique where you map your landmarks before you inject, you're going to mark your coracoid, and you're going to come somewhat inferior to that for your injection. But again, anterior shoulder dislocations being the majority of what we see, a posterior approach is probably the way to go in most of these. So this guy, our case, we go back to him. We did several more attempts. We used the ultrasound, and then we were happy. We thought it was in, verified success, and he didn't need any more sedation, didn't have to get a bunch of repeat X-rays, and we were all happy. So a couple of pearls or pitfalls about the shoulder. It can start to get confusing when you're in the back of the patient, you're in the front of the patient. Thought I'm always supposed to put the indicator to the patient's right, but what do I do when I'm in their back? put the screen in front of you and line up the indicator with the way it looks on the screen. So most of the time, if the screen's in front of you, the indicator's on the left of the screen, you're going to want the indicator on your left. So put it to the operator left. That way it matches the patient's anatomy, matches the anatomy on the screen. Does that make sense? And that's a general, with procedures, you just want to match what you're seeing anatomically with what you see on the screen. And don't think so much about patient's right or left for the indicator. If you're doing needle guidance, carefully visualize your needle as you're placing it into the joint. Questions on the shoulder? Pretty straightforward, and I think we see a lot of shoulder dislocations, so I think that could be pretty useful. So some other joints we're going to talk about. Other joints that maybe we don't see so frequently, and maybe we don't feel as comfortable dealing with these joints with landmark techniques or without some better visualization. So just some of the evidence behind ultrasound-guided joint aspirations. In rheumatology clinics, when they went from landmark techniques to ultrasound-guided techniques, they found a 300% improvement in their success rates. And those are guys that put a lot of needles in a lot of joints. They also do a lot of small, tiny joints that we don't necessarily do that much, so there could be some bias there, but still pretty impressive, I think. Some other studies talk about failure rates before and after ultrasound-guided techniques, and just some failure rates of palpation-guided injections. And you can see a lot of these landmark techniques that we see in Robertson Hedges or that we've been taught in medical school, even though they work a fair amount of the time, they don't work all the time. And ultrasound can really affect our success rates and how many times we have to stick the needle in this joint. So, pretty good tool. So I want to talk about the elbow. Who here has tapped an elbow? Yeah, not that many. We don't tap elbows on a daily basis, which leads to the reason ultrasound maybe is a good tool, because we're not as comfortable with it. We don't do it all the time. It's a smaller joint. So if it's difficult, or if you want to improve your confidence, success rates, ultrasound, again, maybe a tool that helps you improve your aspiration of the elbow or your injections in the elbow. So a quick reminder of the anatomy. Big point is this posterior view here, the olecranon fossa, because that's one of the pieces that we're going to focus on as far as ultrasound. And I just want to point out the landmark technique differs a little bit from the ultrasound guided technique. In the landmark technique, you find the triangle on the radial side, and that's your target where you're going to place your needle and aspirate. Ultrasound is a little more from a posterior approach, and that's what I'm going to show you here. And again, high frequency transducer, the elbow joint's pretty close to the skin, and a posterior approach, and you're going to image this in sagittal and transverse planes. And here's what it's going to look like. So in a sagittal plane, here's the distal humerus, and there's this recess with a fat pad here, and this is the real proximal ulna right here, and that's your joint space. In the normal joint, there's almost no fluid visible. We all know theoretically, there is a small amount of synovial fluid in every joint, but in most normal joints, there's not that much visible fluid, and there's just a little fat pad there. And here's a transverse view, right in that olecranon fossa that dips down, a little fat pad, and that's our joint space where we're going to look for fluid. So here's some pathologic images. There's that olecranon recess, and here's fluid in that joint. And here again, you see, here's the fat pad on the top, and it's being elevated by a joint effusion in the elbow. Relatively easy to appreciate. Black stuff, fluid in the joint.
When you do this, is the elbow flexed or?
Flexed and supinated is the standard technique that I've been taught and everybody usually talks about. So 90 degrees, about like this. And you want to, so you've identified the effusion. Again, you can map out your landmarks and then place your needle, or you can visualize it directly with ultrasound and then place your needle. Whatever you feel more comfortable with. Most of the time, I like to do it directly visualized. It's a little bit harder because you got to have the cover on top of the probe and that kind of thing, so that makes it a little more difficult. But these map lines, they move a little bit and your lines are in the wrong place, so I like to do it under direct visualization. So you want to aim for the deepest point. Remember, you got the ulnar nerve over here and the triceps tendon is right in the midline, so you want to come in laterally and then approach that deep recess in the olecranon fossa. With the elbow and any of these things that we're talking about musculoskeletal things in the arms and legs. Compare the other side to look for big differences. And then, like we said, approach laterally. That ulnar nerve lies medial. You don't want to hit that. Make sure they haven't had an ulnar nerve release. And the triceps tendon midline, try to stay away from there. Questions about the elbow? Elbow's pretty straightforward. All right, who's done hip before? We don't do the hip very much. In fact, I would say without ultrasound, you probably don't want to do the hip. But with ultrasound, the hip becomes pretty easy. So, just as a background on the hip's a pretty deep joint, hard to palpate the landmarks. And who's arranged for a hip tap before? It's painful, right? We make 10,000 phone calls. Fluoro's not ready. We got to get an operating room. We're going to inject the joint. And that's if you're here, where maybe you can get that. If you're at a community place, it's not going to happen. You're going to transfer the patient to somewhere where they can get their hip tapped. So that leads to treatment delays and frustration for everybody involved. But with ultrasound, we may be able to change that. So just to review the anatomy. So along the femur, and then you got the femoral neck. This is where the joint capsule is, and here the red is the synovial membrane. You can see it extends all the way down, most of the way in the femoral neck, and that's going to be our target. So again, usually a high-frequency transducer. Depends if you've got a bigger patient, you might need to use a lower-frequency transducer if it's pretty deep to visualize this, but in most cases, high-frequency transducer is going to work, and it's a sagittal oblique view. Again, you're trying to mimic cut your beam right down through the femoral neck like this. So it's not quite sagittal, it's not quite transverse, it's oblique. You want to point it up towards their belly button. And again, don't neglect the sterile prep like we do in some of these diagrams. Here's what a normal hip's going to look like. There's the femoral head, there's the neck. Not really any visible fluid. Here's another example, femoral head, neck. You can see the synovial membrane on top, and there's no fluid there. Everybody see that? Here are some more normals. Here's another adult, femoral head, no fluid. Here's a pediatric, so the growth plates aren't fused. And there's the nice thick synovial membrane. Remember, most people have two hips, so if you're not sure, compare sides so it makes it easy to tell the difference. Here's some pathology. So here's femoral head, neck, largely distended with fluid. And most textbooks will say you should measure that and it should be at least 5 millimeters to be a significant effusion. Here's another one. There's the synovial membrane, and you can see how it's pushed off of the bone with fluid in it. Who here has done ultrasound-guided peripheral IV? Lots of people, right? So when I think about doing these procedures with these joint spaces and these fluid collections, I think if you can do a peripheral IV that's about the size of an 18-gauge needle or maybe just a little bit bigger than that, all of these things are bigger than that, much easier targets to hit. So that's why I make you guys practice peripheral IVs, because if you can do those, you can do any of this needle-guided stuff with ultrasound. So find the effusion, find the vasculature. So often once you've found the effusion, turn transverse and just see where the femoral vessels are, so make sure you're going to be far away from those before you place your needle. And then place your needle in a long axis. Again, direct visualization I think is best. Pearls, pitfalls to the hip. Again, compare sides. I think you should always compare sides. Identify the vessels and use a long needle. Don't walk in there with your standard 18 gauge and think you're going to get there. You usually probably need a spinal needle or get one of the needles out of the central line kit, something that's a little bit longer, give you plenty of room. Questions about the hip? Who wants to go tap a hip? It's exciting. How about the knee? Sometimes you might read about ultrasound-guided arthrocentesis of the knee and you think, why would you need to do that? We tap knees all the time. It's a huge joint. You always get fluid out of it. Nobody ever needs to ultrasound for arthrocentesis of the knee. But I would argue that sometimes you do. Who's ever gotten a dry tap on a knee? Hate it. Nothing more frustrating. Not much more frustrating. Or maybe you've seen a patient like this. Which knee, let's see a show of hands. Which knee hurts? Who says right? Got one for right. Who says left? A lot of lefts. It's right knee. I couldn't tell. So this guy's right knee hurts. You can't tell anything on exam except he doesn't like to move it. It's not warm, it's not red, not appreciably swollen. So sometimes maybe ultrasound helps on a patient like this. And we have a few patients like this that come to our emergency department, I think. So a reminder of the anatomy, remember the synovial capsule extends throughout the joint and then comes way up pretty high, suprapatellar, and that makes it pretty accessible up there, and that's where you can ultrasound it. So the technique, again, high-frequency transducer, and you're gonna look in different spots around the knee to see where the fluid is, where's the best spot to put your needle. And you're going to stick it right by the patella, and you're going to aim your beam kind of down towards the midline of the tibia and the femur. And you want to look up high, you want to look at the sides, and even down low. I'll even come up right in the midline, right above the patella, and then kind of go side to side from there to find where that fluid pocket's going to be. So here's some normals. There's the patella right there, dense white cortex, dark shadows. There's the distal femur. There's the quadriceps tendon. We'll talk about tendons later. And there's really nothing there. And if you come more medially, distal femur, proximal tibia, here's the joint space, and that looks pretty normal. That's the MCL going across there. And so here's some pathology. There's not a lot of landmarks because depending on where you go, you're just going to see these fluid pockets. Depending on how chronic it is or if they've got underlying gout, you might see some echogenic material within those fluid pockets, or it might be simple fluid, or might be more hemarthrosis, a little more complex like this here. There's some simple fluid in the knee joint. There's hemarthrosis. And those are you're going to see where you have the most fluid, and that's where you're going to stick your needle. And most of the arteries don't run in the front of the knee. Most of the nerves don't run in the front of the knee, so you're pretty safe with the knee. So you're going to find the fluid in two different planes, and you're going to put your needle in it. And you can see in this diagram how high they are. Now, a lot of these diagrams show this two-operator technique. It's a nice technique if you have two operators and you know where this tubing is all the time. I can never find it. It works just as well with a syringe and a needle and a single operator. Be careful. There's other fluid collections that gather around the knee. Prepatellar bursitis, and if I go back, so if you're looking prepatellar and you see this quadriceps tendon and you see fluid in front of that, then that's prepatellar bursitis. If it's knee joint effusion, it should be posterior to the quadriceps tendon. So look for that when you're doing your ultrasound. If you happen to look behind the knee, which that's not where you're usually going to look for a knee effusion, but if you look behind, you'll see this. You might see a Baker's cyst, and don't confuse that with a knee effusion. Classically looks like a stomach. I can see that. You guys see that? So compare sides. You see that, Rick? No? Yeah? All right. Questions about the knee? Who wants to try ultrasound of the knee? Anybody? All right. I appreciate that. How many people have tapped ankles? So not a lot of our residents tapped ankles. We don't tap ankles very much. Again, another reason that the comfort level isn't quite as high for the ankle. It's not as big as the knee. The general place where you tap the ankle is pretty close to some important structures like the dorsalis pedis. So that makes it another thing. It makes it a little scarier. So a reminder of the anatomy of the ankle, synovial membrane, and kind of here's where our target's going to be. And this is some of the relevant anatomy. Distal tibia and the talar dome. So again, high frequency. Mostly you're going to identify the fluid in the ankle by a sagittal approach. You're going to be anterior, long axis, kind of like this guy's doing. And so here's what you're going to look for. Here's distal tibia. Here's the talar dome. You got this triangle shape down here. Notice all these joint spaces kind of look the same. In ultrasound, sometimes they call this the seagull sign. Maybe that looks like a seagull. I don't know. Maybe that looks like a seagull right there. But that's another normal distal tibia, talar dome, and really no appreciable fluid in that space. So a normal ankle joint. And here's the pathology. Distal tibia, talar dome, fluid pocket. Needles fit right in there perfectly. And here it is again. Tibiotalar effusion. Here's just some other ankle effusions. This person happened to have gout. Here's a transverse view. So they've identified this effusion. They've turned transverse. Right there is dorsalis pedis artery. So stick your needle here or here, not here. Okay. So once you find the fluid, look for the vessels so you know where they are so you can avoid them. And then stick your needle in there. And again, you can map it out and do it, or you can just directly visualize your needle with ultrasound, which is what I prefer. And aim for that deepest spot within that recess, and you should be pretty successful. Questions about ankle? That was pretty easy. You guys are good at this. There's really no big pearls. Just make sure you find the arteries and try not to hit them. All right. Questions on any of the joints? If you can do one joint, you can pretty much do any of them. All right. And you could do MTP joints. You can do the wrist, fingers. I stuck with the big ones for now. Practice with those, and then you can move to the small ones if you want.
Do you just do like topical anesthesia? I mean, you just make a real
Yeah, just local anesthesia. Or if you're an orthopedist, you don't use the anesthesia because one needle versus two needles. You could debate that. I usually give them some local, right where I'm going to stick them. So here's our next case. A 43-year-old female. She tripped, fell on her outstretched hand, kind of back behind her, and she comes in. She's got pain and swelling of her wrist. Compartments are okay. She's neurovascularly intact, but she's got a lot of pain. Anybody seen a patient like this recently? This isn't like foreign to anybody. So she's in the room, she's in pain, she's supposed to go for Xrays, but she wants something for pain before she goes over, so let's take a look, let's ultrasound her. So this is her distal radius. Here's the distal end, and here's the proximal end. There's the dense white cortex, Those should be connected, but they're not. So this is her distal radius fracture, and it's pretty displaced. This is just another view. I think this is the dorsal view, and this is the lateral view. So everybody can pretty clearly see those cortices that don't line up, right? So that's distal radius. That's what that looks like. And again, I picked this topic because I think it's one of the more useful ultrasound pieces of the bone that you can do. But if you can ultrasound a distal radius, you can ultrasound any bone. So here's what her X-rays look like. She did go for X-rays. I still do believe in radiation on occasion, even though I love ultrasound. And here's what it looked like. It's dorsally displaced. It's fragmented. It's kind of an ugly fracture. So what are you going to do? Dr. Semino, what's your plan? You could call orthopedics. You're at UHC. Orthopedics says fix it and not send them to the clinic. Splint? I think she should eventually get a splint. That's a good plan. Dr. Saib, what do you think? Any other plans? Stick her in a splint. She can follow up. Yeah, I wouldn't really just talk about it if that was all I was going to do. So you can do hematoma block and close reduction. So there's different ways you can do a close reduction. You can just blindly do it, put them in a splint, and then send them for the X-rays. A lot of people do that. Success rates aren't that bad. That's a perfectly appropriate way to do it. It really stinks when they come back and you got to take their splint off again and try again. It's not fun. It takes a long time. So you could do fluoroscopy, which we have here. We have a mini C-arm that we can use. If you do it at UHC, you got the big C-arm. It doesn't fit in most of the rooms. It doesn't work very well. But you can do that. Or you can do ultrasound. And of all the things that we've kind of talked about, this is the thing that actually has probably the most good evidence behind it. There's several papers demonstrating the utility of ultrasound for distal radius fractures. And what the evidence shows, can do it with fewer attempts, better alignment. There was small significance, but was significant number, reduced need to actually go to the operating room later, so that's pretty nice. And you don't have to radiate them. And evidence doesn't say this. I made this up because that's what I think from my experience is you actually get better views, because when you use even the mini C-arm, you can never get it turned right to get the good, perfect AP view or the perfect lateral view, or you're always bumping into the patient. So you're always at some oblique view trying to judge how good your reduction is. So again, high frequency transducer is what you're going to use. And you want to do dorsal and radial views. You can also do volar views. So if you have the transducer here on the radius of the patient laterally, that kind of is the same as getting your lateral view on the X-ray. And then from the back, dorsally, that's like your AP view. So you want to look in both of those planes for the alignment of your distal radius. And so you're going to really reduce this the same way you always would. And then when you think you're happy, ultrasound it first before you put your splint on. And if you're not happy, keep working on it. If you are happy, go ahead and splint. And then if you want to send for X-rays afterward, go ahead and do that. So here's did I hear a question? No? Here's some examples. So here's pre-reduction, not really lined up very well, and post-reduction, those cortices are a lot closer. And this is our example. So the lateral view, a lot closer, and dorsally, a lot closer, less tilt in the dorsal plane. So this patient got ultrasound guided reduction and actually did simultaneous ultrasound and fluoro. By fluoro, it didn't look very good. By ultrasound, it looked good. And over for X-rays, looks pretty good. A lot better than it was before, much improved. So like I said, if you can do ultrasound of a distal radius, you can ultrasound any bone. They all look the same. They all have dense white cortex and some kind of shadow behind. So here's a rib fracture. Here's a metacarpal. There's literature out there about scaphoid fractures, the ones that don't show up very well in X-rays. Remember those? Mandibles, nasal bones. Any bone that you can stick the probe on, you can ultrasound for fracture if you'd like. So for the distal radius, make sure when you're getting your views, get two planes, so a dorsal and a radial view. And you're going to start kind of looking at where they're most tender, where they're most swollen. One little pearl about doing the reduction is usually I tell you to be really generous with the gel and slop it all over everything. But for these, when you're trying to manipulate things, you don't want a sloppy wrist. So get just enough gel on the probe to do your views, and then have a towel ready so you can wipe it off so that you don't have slippery fingers when you're trying to reduce them. Questions about bone ultrasounds at all? Dr. Alonso?
Did you ever use ultrasound to replace the hematoma block?
I have not, but there's some studies about that. There's some case reports about it. Another potential use. I'm looking forward to trying it. So I just wanted to briefly talk a little bit about ultrasound of the tendons. This is another area that people are doing more and more, and we've done some here just so you're familiar with it, and maybe you can use this in your practice to give you some more definitives rather than maybes when you see these patients. And the real question is it torn, yes or no? Like, We usually say ultrasound needs simple questions and simple answers. So your yes/no question is the tendon torn or not? And if it is torn, does it look like it's partial or does it look like it's complete? So we'll use the Achilles for kind of our demonstration here, but any tendon you can think of, you can ultrasound it. High frequency transducer. Tendons are easier to visualize in a long axis technique. Once you find them and identify them in a long axis technique, you can see them in a short axis, but I'm going to mostly show you long axis views. So they're pretty bright, echoic, kind of white compared to like muscle. Muscle's pretty black. Tendons are a little brighter white, and they've got this fibrillar appearance. Does everybody see that? I don't know why that's on there. And this is a FDP tendon. It's well intact. Just another example, fibrillar pattern, pretty bright white, pretty easy to follow, nice and continuous. Everybody see that tendon there? It's pretty easy to appreciate, I think. And so there's this term out there when you ultrasound tendons called anisotropy. And I just pointed out so that you don't get fooled when you see this. And if you take the musculoskeletal ultrasound boards, this term comes up. So if any of you are looking into taking those boards, know this word. What it is when your ultrasound beam strikes a tendon, so here's our tendon of interest here. If the ultrasound beam strikes at pretty much a 90-degree angle, you get good ultrasound beam return, and so you get this nice image of the tendon. But when the tendon curves, now our ultrasound beams are coming at kind of an oblique angle to the tendon, it gives you this like a disappearing tendon sign. And that can make you think that you have a torn tendon, but you don't have a torn tendon. This is anisotropy. And so how do you get around this is you just look at the tendon in different angles and see if it's continuous or not, or if there's really a tear there. And so this is this same tendon here. We've just moved down the plane a little bit and gotten to a more of a 90-degree angle, and we can see this tendon is intact. So this is just the continuation right here that we're seeing. This is just normal tendon. So if you see something looks like that, try to get at a 90-degree angle to it and see if that blackness persists and if it's truly a torn tendon or not. Does everybody see that? Does that make sense? If you don't remember that word anisotropy ever again, just remember to image tendons from about a 90-degree angle. There's the example if you need to see it. So the pathology, when you're looking at tendons, it's either going to be missing, so you're going to know where the tendon should be, and you're going to look for it and not find it. You're going to compare it to the other side. It might look hypoechoic or have fluid collection around it. If you compare sides, it may look thickened. You might see calcifications around it. Those are some of the things you're going to look for. So this is a patient who had knee pain after some forceful flexion. So this is their patella, and this is superior to that patella. So this is towards the patient's head. And here is inferior to their patella. Here's their patellar tendon. See that nice fibrillar echoic appearance? Can't find that up here. Quadriceps tendon looks about like the patellar tendon. It's just in a different spot, but it's not here. And this patient can't extend their knee. So that's a complete quadriceps tendon rupture. They see that pretty well? In case you didn't, I highlighted in yellow. Here's something you could get lucky enough to see. This is an Achilles. So here's the proximal, here's the distal, and we're hitting this at 90 degrees, so this is not anisotropy. This is just discontinuous tendon with fluid collection. So that's the tendon tear. You might see it really visible there. Here's another one where you have Achilles. You can find Achilles all over the place. This is the one that everybody tears and everybody likes to ultrasound. There's your fluid collection. Again, you're hitting at 90 degrees, so that's not anisotropy. You just have a tear in the tendon. So the yeah, Dr. Saad.
So when we're looking for tendons, I typically look for slide. Now I've never seen an abnormal or torn tendon. So what I'm viewing that will I find the end of that tendon and get the slide, or is it just there?
So are you talking a partially torn tendon or a complete tear?
Complete.
In a complete tear, you're probably not going to see slide. And you're probably not. I haven't seen a case of a complete tear where you can see the tendon. There are some cases where supposedly if there's a missing tendon, you can come up proximally and find the stub. What I have found is the tendon's nowhere to be found. But you should range them passively and actively if they can do active range of motion to see if you can see the tendon and see if you see any movement. And that's part of, so image them through a range of motion to see if it moves and look for discontinuity. And as you image through that range of motion, you might see those defects. And beware of that special word, anisotropy. Actually, I finished early. I was on fast today. So, questions about musculoskeletal ultrasound? Anybody excited about doing it? Anybody want to go tap an elbow right away? I do. All right. Dr. Reardon, you just excited about tapping elbows? All right. All right. So I'll just hit you with a brief summary. So the joints, especially the shoulder, because we see that one a lot, and maybe we sedate people, and sometimes they're not as easy as they should be to tell if they're in or out. So ultrasound can help you with the reductions before maybe they wake up or before you keep trying again, before you send for X-rays, and they can help you get needles in any of these joints pretty easily. You can diagnose any bone fracture with ultrasound, and I think distal radius pretty difficult to reduce sometimes. Ultrasound can be really useful in that regard. And with the tendons, a lot of times we see patients and we say, well, I think you have a tendon injury. I'm going to put you in a splint and you're going to follow up. I think we can answer that question a little more definitively than we can without ultrasound. So maybe that'll help you in your practice. All right, thank you guys.
Wait, then I have a question then. So let's say you do image this torn tendon. How much is ortho going to start that?
Just like everything else in emergency ultrasound, we have to continue to lead and teach people.
I mean, like for follow-up, like do you say like torn tendon on ultrasound, or do you just say evaluate patient?
As your comfort level grows and you get practice at it, I think that's perfectly appropriate. Probably not on your first one. You're probably not going to say that.
They actually do this.
Yeah, I mean, I've several